Has optometry abandoned vision therapy? That's a hard question, but it's one we need to ask because occupational therapists are expanding into vision rehabilitation. And that this is nothing against occupational therapists. They are seeing that vision is important. We have done such a good job of showing how critical the development and rehabilitation of the visual system is that they now have no one to refer to because optometrists are not going into vision therapy. So what OTs are doing is, the ones that I've spoken to, they understand that I have devoted, my entire life to vision. They know that I have gone to school only for vision. They know that I have my fellowship only in vision and that I've been, in practice for the last 17 years in just vision. So they refer to me and they refer and they refer and they refer because they understand the expertise that I bring for their patients. However, when their patients are too far, when their patients don't have transportation, when their patients can't afford vision therapy because insurance companies have decided to not, pay optometrists to provide vision therapy, then they need to take it upon themselves to help the patient that's in front of them. One of the main things about OTs is that they have like bleeding hearts. They are angels, And so they want to help every single patient that they encounter. And when that help's not available because we're not accessible, yes, they do need to take that on. And the long and the short of it is a lot of hospitals won't even hire optometrists into the rehab departments. Our large organizations don't prioritize functional vision. And in some regions, VET offices are closing faster than they're being replaced. So the question isn't, are OTs taking over? The real question is, why is vision therapy slipping away from optometry in the first place? Let's be clear, this isn't about ego, it's about structure. Healthcare doesn't reward depth, it rewards accessibility. That's the uncomfortable truth. Where are OTs? Hospitals, rehab centers, school systems, insurance networks. Where are most VT doctors? Private self-pay practices? Geographically limited? So, when a hospital builds a concussion program, are they really going to search us out? Are they really going to hire the only behavioral optometrist that's around? Or are they going to use their network of OTs that are very plentiful and people that they can, move around and replace and can work in their schedule and not just on our schedule? When optometrists contract with hospitals and the hospitals that do allow them to contract, usually the optometrist is giving them like a day every week, maybe every 2 weeks, maybe a month, and it's these specific hours and everything like that. They're not trying to do all that. They're trying to have somebody on staff who will be working. And if that person, has to leave, has a medical issue, has anything that happens, then that person can be replaced. That's not how behavioral optometry is. That's not how vision therapy doctors are structured because there's not enough of us. And so this isn't personal. This is structural. If families must drive hours, wait months, attend rigid one-to-one in-office sessions, pay fully out of pocket, then modern healthcare systems will look for alternatives. And that's what they found. Not because those alternatives are more specialized, but because they're available. Availability wins. If we remain location bound and labor bound, we shrink our footprint. And when your footprint shrinks, influence shrinks with it. We often say, oh, our large organizations haven't educated the public. That may be true, but awareness without access doesn't scale anyway. If we don't modernize delivery, if we don't integrate into broader systems, if we don't extend beyond one physical location, then we create a vacuum. And vacuums get filled. Not maliciously, but predictably. Vision therapy isn't being stolen, it's slipping. And it's slipping because we tied it to a fragile system. Our structure depends on one-to-one only. Physical presence, local geography, therapist availability. That model limits reach, and limited reach limits influence. Leadership isn't defending the old model. Leadership is evolving it. That means codifying our intellectual property, increasing accessibility, building hybrid models, collaborating strategically, modernizing delivery, not to replace complexity, but to protect it. Because if optometry doesn't build resilient BT systems, we won't remain the leaders of it. Not because we lack expertise, but because we lack structure. Has optometry abandoned vision therapy? Maybe, not sure. But what I do know is that we have neglected to evolve it. And in healthcare, stagnation looks like surrender. If we want vision therapy to remain in optometry, we must make it accessible, sustainable, and structurally strong. In the next episode, I'm going to address the most common objection I hear. Digital can't handle complex binocular work. Let's talk about it.